Thank you, Jerry. Thank you very much. Thank you, Gabriele. Let me thank Enzo for this invitation. I'm very happy to be here. And I'm particularly happy, this is my disclosure, I don't have a conflict for this talk. I'm particularly happy to share this session with an old friend, Geert Biesse. Here we were in Toronto many years ago. He was very young, I was a little less young, but still 10 years ago. And that time, in the Toronto Consensus of Diabetic Neuropathy, the neuropathies developing in patients with diabetes were defined as a very heterogeneous condition, particularly in terms of symptoms, neurologic involvement, but also underlying mechanism. Much more recently, about 2 years ago, the American Diabetes Association position statement defined diabetic neuropathies as the most prevalent chronic complication of diabetes, and again underline the wide heterogeneity of this condition. Now, though so prevalent, diabetic neuropathies are in fact, they have some epidemiological problem, which means that epidemiological data are very heterogeneous. They vary a lot from a very low percentage to very high percentage. Actually, in Italy, we have one of the best data on neuropathy. This chapter is part of a book which was published a few years ago by the Italian Society of Diabetes. If I well remember, at that time, Enzo was the chairman. And as you can see, in Italy, we have quite good data showing a prevalence of diabetic neuropathies ranging from 20% in population-based study and primary care up to 28% in secondary care, which is quite good. I mean, quite homogeneous data. Not so homogeneous data from the literature, ranging from very low percentage to very high, obviously depending a lot on the type of studied population, duration of disease, type 1 or type 2, but also depending on the fact that we probably still miss the ideal marker for the diagnosis of diabetic neuropathy. We still miss the microalbuminuria for neuropathy. And of course, we would like to have a marker which should be accurate and reproducible, but also with high sensitivity and specificity, easy to measure, with high predictive value, and possibly early. So in the recent years, DI has been regarded as a possible window for investigating diabetic neuropathy. Therefore, I decided to divide my talk in two parts. In the first part, we will see together the neuropathic eye as a specific complication of diabetes. So we will discuss evidences suggesting that neuropathic eye is in fact a specific complication of diabetes. And in the second part, we will try to analyze the few data, still few, suggesting a possible association between the damage, neuronal damage in the eye and other sites of neuronal damage in diabetes. So the neuropathic eye can be evaluated considering mainly two sectors. One is the cornea, which is a very easy and accessible sector to study, and we will see in a moment cornea has been widely used for evaluating corneal nerves. And the other one, more recently proposed as a neurological evaluation of the eye, is the retina. Corneal confocal microscopy is the gold standard to measure corneal innervation, while optical coherence tomography and OCTA with the angiography part and microperimetry, which is an evaluation of retinal sensitivity, are used for evaluating the neuronal part of retina. And finally, the multifocal ERG is a functional analysis of retina. Corneal confocal microscopy has been widely used in these years, and it has been consistently reported to be associated with other neuronal damages, particularly at the level of small fibers, for example, in skin biopsies, but also more recently with diabetic neuropathy, peripheral diabetic neuropathy. Of course, in order to validate this method, it was important to get some normative values, and that has been done 4 years ago by Mitra Tavakoli. She published this beautiful paper presenting normative values of corneal confocal microscopy, taking into account two main variables. The first, aging. Of course, aging is associated with a reduction of corneal nerves, both in terms of length and in terms of density, and sex. Female and male have different values in terms of corneal nerves. So according to these normative values, we can now have clinical measure of corneal nerves abnormality. And using this parameter, it is possible to show an early alteration of these nerves. This is a population of patients with type 1 diabetes without peripheral neuropathy, and without microvascular retinopathy. And as you can see in this our recent paper, we found in this patient a reduction both in terms of nerve fiber length and of nerve fiber density, thus suggesting that this alteration in corneal nerves seems to be an early alteration in the time course of diabetic disease. More recently, the attention focused on the retina. In this cartoon, I represent the architecture of retina, and as you can see, besides the retinal pigmented epithelial cells, retinal is mainly composed by neuronal tissue, by neurons, both at the level of photoreceptor and then horizontal bipolar amacrine cell and ganglion cells. But other components of the retina have now gained interest in this last year. First of all, the presence of microglia, which has been shown to have immunomodulatory functions, and the glial cells, which are represented by Muller cells and astrocytes. And we now know that these cells exert a role which is behind the supportive role, but they play an important role also in regulating messages between this huge neuronal part of the retina and the vascular endothelial cells. Therefore, despite the prominent vascular appearance of retina, and in fact by fundus, what we see are mainly vessels, retina is a neuronal tissue. Now, the way to measure this neuronal part of retina is by OCT. OCT is a very interesting method, very sensitive. In the very last version of the OCT, the Hydal spectralis, we have now a very precise and sensitive representation of retinal layers, like a morphological analysis. And with this method, it is possible to measure all the different layers of retina, and particularly to divide these layers in the different sectors: superior, inferior, temporal, and nasal sector. Using this methodology, it is therefore possible to measure the single layers of retina. And by doing so, we were able to show a couple of years ago that already in a very early phase of diabetes, type 1 diabetic patients, again, no signs of microvascular retinopathy and no signs of peripheral neuropathy, this patient display already a reduction of ganglion cell layer in the total absence of microvascular retinopathy, or with the very mild sign of microvascular retinopathy, thus suggesting an early impairment in the neurological layer in the retina of this patient. Following this line, we wanted also to examine in the same population, and this is Fabiana Picconi, who did the most of this work, other retinal layer in order to understand whether some other morphological abnormalities could be related in this very early phase of disease. And what we found is an increase of INL, inner nuclear layer, which was consistent across all the quadrants examined, and overall the mean of INL was significantly higher in patients with type 1 diabetes, but without microvascular retinopathy or with mild signs of microvascular retinopathy. And then the question was, what's the determinant of this increased INL? Do we have some predictive factors to explain this increased INL? And what we found was that glucose variability and triglycerides, they were both independent predictors of increased INL. Altogether, it accounted for almost 40% of INL thickness. And as you can see in this figure, INL global thickness significantly correlated both with CONGA2 and CONGA4, two well-known validated parameters to measure in glucose variability, therefore suggesting an important role of glucose variability on this alteration. Now, if you go back to see the cartoon I previously showed you, you can easily see that at the INL level, besides bipolar cells, we also can see the nuclei of Muller cells. Therefore, this increase in INL could represent an increase in the glial component of retina. And this is very much in agreement with previous data. Last year, Raphael Simon published in Diabetologia this nice paper showing both in animal model of diabetes and in retina from donors with type 2 diabetes, a significant increase of INL with a green color representing the activation of GFAP, glial fibrillar acidic protein, which is a specific marker of Muller cell activation, both in the animal and in the human model. Together with this, he was able to show by tunnel a reduction of the ganglion cell layer, the neuronal layer, both again in animal and in men, thus suggesting a phenomenon of apoptosis of neuronal layer. All these findings suggesting that the main features of neurodegeneration are represented by glial activation and neural apoptosis are very much consistent with the hypothesis of the so-called neurovascular unit. What has been proposed, specifically by the group of Raphael Simon, but also suggested by others, is the presence of Muller cells, which could play a role in the interplay in the messages coming from the photoreceptor up to the neuronal cell, finally driving the message to the vasculature. And what is supposed to happen when diabetes onset arrives is that the hyperglycemia is able to activate Muller cells, and this activation of Muller cells would be responsible for the activation of microglia with the release of growth factor and chemokines, which in turn will provoke a disruption of cell-cell junction at the vascular level and final neural apoptosis. Therefore, the hypothesis we can derive from this possible scheme is that in our in vivo data, the glucose variability was in fact able to trigger Muller cells and to activate them. And that's what we wanted to test in this in vitro experiment. In this paper, immortalized rat retinal Muller cells were maintained both at low normal glucose, 5 millimolar, or high glucose, 25, And then they were triggered with a different glucose level, high glucose, normal high glucose, low high glucose, and the activation of Muller cells was measured as GFAP expression. And as you can see, and I think this is very interesting, only in cells previously maintained in normal glucose at 5 millimolar, high glucose and oscillating glucose were similarly able to activate Muller cells, while such an activation was missing in cells previously maintained at high glucose, thus suggesting that possibly a maximal activation already occurred in this population of cells, and they were not more susceptible to be furtherly activated by glucose variability or high glucose. Therefore, this data seems to support the hypothesis of an early activation of Muller cell in a patient with very early phase of neurodegeneration. Now, so far, therefore, the hypothesis is neurodegeneration and early microvascular impairment. They start together. A lot of questions about egg and chicken in this story. We still don't know, but what we think, what it is hypothesized, is that they start possibly together, but then the progression of neurodegeneration up to glial dysfunction and neuron death will be responsible for the final impairment in vascular cells with vasoregression and impaired hemodynamic response. Now, this bidimensional model seems to be not enough representative of what we have seen so far. And last year, Abramoff proposed this different model where the terms diabetic retinal disease has been proposed to include both the retinal microvascular complication and the retinal neuropathy caused by diabetes. And as you can see in this scheme, the two arrows are not necessarily interrelated, at least not in each. The progression of one arrow is not absolutely and totally dependent by the other. And this seems also to be demonstrated by the observation of patients with a very high level of neurodegeneration, very, very advanced neurodegeneration, without signs of microvascular retinopathy. Therefore, our purpose in the future years will be to describe these arrows and to see the natural course of diabetic retinal neuropathy versus diabetic microvascular complication, the one we know better. Of course, to do this, to make a real analysis of progression, we should have longitudinal studies, which unfortunately are very few. One is this. 3 years ago, it was published in a group of type 1 patients, quite good selected patients, quite young, duration of disease not that much. And according to this study, the progression during a 4-year follow-up of retinal nerve fiber layer loss was of minus 0.25 micrometer per year. Of course, very much more than in the general population. These data should be taken carefully because at that time we didn't have the Heidelberg spectralis, so the analysis of the retinal layer was done with less sensitive instruments. And that could be one explanation for this, our very preliminary data. We are following children. They have a mean age of 15 years of onset of type 1 diabetes, a very short duration. And during the first year follow-up, we were able to show a much higher progression, 0.85 micrometers. Of course, again, this can simply reflect the difference of sensitivity of the instrument, which could be, or could also reflect the fact that during the natural history, the very early phase of disease could be characterized by the most important loss in terms of neuronal tissue. Of course, we don't know And of course, we need to prolong the follow-up to give an answer to this hypothesis. I would like to conclude this first part by saying that the neuropathic eye, from what we have seen, is in fact a specific complication of diabetes. Now, which data do we have to support the idea that neuronal damage in the eye is associated with other neurological complications of diabetes? For corneal confocal microscopy, data are very strong. Corneal confocal microscopy has been widely tested against a lot of measures of peripheral neuropathy. This is the most important paper. Bruce Perkins was able to collect a large number of type 1 and type 2 patients, and he was able to build the ROC curves for type 1 and type 2 against the standard criteria of the Toronto Consensus, including electrophysiological abnormality. And as you can see, he got very good data, very good number in terms of sensitivity and specificity, particularly in type 1, a little less in type 2, but still good, probably in type 2, reflecting the wide heterogeneity of this condition also in terms of neuropathic complication. Much less data on the neurodegeneration. This is a paper of 3 years ago, just examining retrospectively 160 patients. And as you can see in this paper, signs of neurodegeneration were well correlated with various measurements of peripheral neuropathy, particularly peroneal nerve velocity and posterior tibial nerve velocity. Of course, this paper, though very numerous, has the problem to be a retrospective paper, so data are in patients with already established complication is just a correlation. A very more recent, at the same period, this beautiful paper from the group of Professor Pugliese was very interesting because it was able to show not only this reduction in retinal nerve fiber layer, but it was able to show that the average reduction of the nerve layer was, in fact, significantly correlated with the diabetic peripheral neuropathy score, but not with diabetic retinopathy, thus suggesting that this measure is much more important for measuring peripheral neuropathy than for measuring the classical diabetic retinopathy, microvascular retinopathy. And these are the specificity and sensitivity for this parameter, which was quite high. But of course, in this stage of disease, we have all complications already there. So our purpose is to try to find something very early. And on this purpose, we can use the so-called motor unit number estimates. Here you see normal mice with the green nerve terminals and red acetylcholine receptors. In hyperglycemic mice, what happens is that there is an early apoptosis of neurons. But at the very beginning of the process, in order to maintain the overall maximal compound preserved, the surviving neurons will sprout their axons to innervate fibers who lost their own neuron. So what happens is that we finally have a preserved compound, a maximum compound potential, but we have an increased area of innervation. Overall, the ratio between these two measures is able to show us the number of neurons, the motor unit number estimates. So by doing so, we were able to show in a patient with type 1 diabetes in a very early phase the reduction of the NUN, motor unit number estimates, at the level of the abductor hallux. And in the same population, the electrophysiological evaluation of retina by multifocal ERG was able to show a reduction in the amplitude at each sector analyzed, thus suggesting the contemporary presence of a motor unit alteration and very early signs of retinal functional dysfunction. And the two parameters very well correlated each other. Now, another aspect which has been recently evaluated to try to correlate neurodegeneration with other sites of neuronal damage is the brain. This paper, published a couple of years ago by the group of Raphael Simon, very nicely showed a significant correlation of retinal sensitivity with alteration, cognitive function. And this was observed both in patients with Alzheimer's disease and in patients with MCI. And retinal sensitivity was also able to predict some parameters of volume of the brain, particularly in this picture, gray matter volume was significantly correlated with retinal sensitivity, thus suggesting that the evaluation of retina by microperimetry could be an easy and early method to assess the Alzheimer's disease in a very early phase. And this is actually our project. We were starting now with Geert also, again with me. And the idea is to understand whether retinal and cognitive dysfunction have common pathways and whether microperimetry can be used for the diagnosis of patients at risk of dementia. So I would like to conclude saying that retinal neuropathy caused by diabetes is characterized by an early reduction of neuronal tissue and an early activation of Muller cells. Glucose variability is associated with an activation of Muller cells and seems to be at least as important as overall glycemic load. Retinal neuropathy caused by diabetes is a specific complication of diabetes. And finally, recent data suggests an association between retinal neuropathy and central and peripheral neuropathy in diabetes. I would like also to thank all the people working with me, particularly people from endocrinology, diabetes and metabolism of my university, but also people of the neurology of the Santa Lucia Hirsch Foundation, of the Bietti, where all the ophthalmological evaluation have been performed, and also my AFAR division of my hospital, which gives a lot of support in the analysis, in the statistical analysis. First of all, let me thank, the most important person is Fabiana Picconi, and I would like to underline the enormous amount of job she did, facing a lot of clinical activities, which every day are not so easy to afford. So thank you, Fabiana. Thank you, all you, for the attention.
Thank you very much, Simona, for excellent lecture. I did learn a lot of new things, and I also appreciated very much the fact that with your topic, nerves, you started from retina, reminding us that retina and nerves actually all belong to the same nervous system, so they are, as we know, very vulnerable to even small elevation of glucose in blood over time. I just have one question while waiting for questions from the audience. You said that variability in glucose is associated with this damage to the retina, neural retinal layer. As you know, there is a controversy in a way between the ones who believe that it is mean daily blood glucose as reflected by A1C to be the driver of early damage in type 1 diabetes versus the ones who believes, on the contrary, it is more the fluctuations and glycemic variability. So how do you see the dynamics of hyperglycemia versus fluctuations?
Thank you, Jerry. This is a very difficult question. Of course, we don't have any data to support that hyperglycemia is less important than glucose fluctuations. The observation of this impact of glucose fluctuations, in my opinion, seems to suggest that probably even when overall glucose metabolism is well addressed, because in this patient, most of the paper I showed you were characterized by a very good metabolic control. Probably this is not enough. And I think this is start to be quite in agreement with also data analyzing, for example, DCCT, showing that not only HbA1c is a parameter to predict the development of microvascular complication, but, for example, time in range, which is in a certain way a measure of variability. So I think we have to learn a lot about the role of glycemic variability, and I think the problem is that we still miss probably robust data of outcome with this parameter, because we still didn't have in the last year enough methods to evaluate this parameter. But according to reason that I think we can strongly suspect that glucose variability can impact behind overall glucose control.
Thank you. I think your data actually do point it out that we should have zero tolerance for hyperglycemia in type 1 since the very early diagnosis. We should not actually wait or postpone any intensification of treatment because of the evidence you provided us with.
Yeah, on the other side, I would also suggest to have no tolerance for hypoglycemia, because we also found, I didn't show you data, but there was a very good correlation between the low blood glucose index and the retinal nerve fiber layer, thus suggesting that also the presence of a prolonged period of hypoglycemia can be dangerous for the nervous cells.
So, questions from the audience?
Simona, thank you very much. Very brilliant lecture. I would like to ask you any more information about the biochemical mechanism of neuroretinal degeneration and possible link with peripheral neuropathy.
Thank you, Cristiana. This is a very, very interesting issue. A lot of studies have been performed during the last year trying to address the biochemical pathways linking neurodegeneration to microvascular impairment. There is a lot to say. I would like to synthesize by saying that glutamate seems to have a very important role in this story. Glutamate is in fact released by all the neuronal cells, and it is specifically, the release is specifically linked to the message, to drive the message, but then glutamate should be taken by Muller cells. So one possible role of Muller cells dysfunction should be that they are not enough able to reuptake glutamate, and so the excess of glutamate could be one responsible pathway for this, which is called I don't know how to say it, excitatory phenomenon. Together with this, of course, there is a lot about inflammation and a lot also about the possible role of anti-inflammatory. There are some experimental data trying to address whether some, for example, there is something with flavonoids are able to, in some way, stop this pathway by being against the inflammation phenomenon.
Thanks, Simona. Great presentation. Do you think that corneal confocal microscopy and neural assessment of retina may indicate different types of neuronal damage? As far as I know, the corneal confocal microscopy evaluates mainly small fibers and correlates with skin biopsy data. What about the retinal data?
Thank you, Giuseppe. I think this is a very important question. We have been used to consider different parts of neurological damage in diabetes as different conditions, and we also been used to consider some of these alterations to be earlier than others. For example, the idea that the sensitive impairment is very early, while the motor unit impairment is later. My personal opinion also related to the very last findings in the literature is that neuropathy is neuropathy everywhere. And so motor neuropathy is probably together with sensitive neuropathy with small fibers. The difference is the methods. We didn't have methods to measure small fiber neuropathy besides skin biopsies, as you said, but as you know, it's not that easy to do. So now the possibility to evaluate corneal nerves with OCT is, of course, a very sensitive method. And the same for motor unit number estimates. We now know that a very early motor alteration is already there. We didn't measure it yet in the past because we had measures of peripheral neuropathy which were not that sensitive. So my idea is that neuropathy is everywhere. It's a matter of finding the right method to measure it.
Brava Simona, thank you very much for this very elegant presentation. You pointed out to a relationship between impairment in the central nervous system and peripheral neuropathy, and even at the level of the eye, of course. You also pointed out the role of inflammation, chronic inflammation, the role of glucose fluctuations. So this brings me to consider whether there is any information about some treatment that could sort of bring everything together, like, for instance, GLP-1 receptor agonists that have been claimed to have a neuroprotective effect, even at the level of the peripheral nervous system. There's animal data suggesting that GLP-1 can facilitate the sprouting of new nerves, improve nerve conduction, and so on. So where are we staying? Do you have any data on the effect of GLP-1 on the specific parameters we have been looking at?
Thank you, Stefano. This is a very important question, and in fact, the obvious idea coming from this data is to try to find a therapeutic option, and GLP-1 seems to be a very good idea. The problem with GLP-1 is that when you use GLP-1 systemically, of course, you reduce a lot of things. First of all, glycemia, and of course we know that glycemia can impact on neurodegeneration. So it's quite difficult to dissect the effect, the direct effect on retina with the overall systemic effect. But some preliminary data, both in animal models and in humans, for example, with eye drops of GLP-1, seems to suggest a beneficial protective, also coming from the group of Raphael Simon, seems to suggest a very beneficial effect of GLP-1. Therefore, the future will be, I think, this and not to use other possible drugs or anti-inflammatory drugs, because we now have the drug which can do everything, I mean, both at the central and the neurodegeneration level.
Sticking to possible therapeutic options in the future, all the microvascular retinal damage is modulated by vascular endothelial growth factor. What about neurodegeneration? Are there any data available on the possible effects of anti-VEGF?
Thank you. This is also a very important question. Of course, we have a lot of data with anti-VEGF on the microvascular retinopathy. Unfortunately, we don't have specific data with the neurodegeneration part better. We do have, I mean, there is a positive impact of anti-VEGF also on neurodegeneration, but we still don't know exactly the egg and the chicken again. So are we working on the microvascular impairment or are we directly addressing the neuronal damage in the eye? This is something we should test. But of course, anti-VEGF are very popular, and they have been tested widely also in this field.
If there are not any, yes, there is one additional question.
Thank you, Professor. Very, very, very nice. Just following a previous point you raised about looking at neuropathy as a whole. So we showed a couple of years ago that the corneal confocal microscopy may also predict cardiac autonomic neuropathy. So you have also data about corneal neurodegeneration and cardiac autonomic neuropathy?
Thank you. Very, very, very important question. There is only one paper, the one I've shown you on SON, in the overall population with chronic complication. Retrospectively, an association was found also with autonomic impairment. But again, it is a retrospective paper, and there is no possibility to be sure that this correlation simply reflects the fact that we are studying very complicated patients. In our hands, in this young population, at the moment we didn't find any correlation. Our purpose will be to evaluate the predictive value of neurodegeneration in the children and see whether this can be considered predictive for the subsequent development of cardiac autonomic neuropathy.